прослухати відеозапис лекції лікаря-пульмонолога Хагіт Левін на тему про особливості лікування м'язової дистрофії Дюшенна після втрати рухливості та респіраторні ускладнення у таких пацієнтів з Дюшенна Беккера. Профілактичні заходи.
And now we invite Dr. Pulmonologist Hagіт Левін with her lecture on the topic of features of Duchenne muscular dystrophy management after loss of ambulation and respiratory complications for such patients with Duchenne Becker.
Хагіт Левін, доктор медицини, дитячий пульмонолог, Інститут пульмонології, Ізраїльський дитячий медичний центр Шнайдера, нейром'язова клініка та клініка неінвазійної вентиляції, клініка муковісцидозу, клініка астми та інших захворювань дихальних шляхів, працювала дитячим пульмонологом та педіатром в декількох медичних центрах, соавтор низки наукових публікацій.
Хагіт Левін, Doctor of Medicine, Pediatric Pulmonologist, Pulmonary Institute Schneider Children's Medical Center, Neuromuscular Clinic and Non-Invasive Ventilation Clinic. She worked as a pediatric pulmonologist and pediatrician in various medical centers, one of authors of a number of scientific publications.
Hello, my name is Hagit Levin and I'm a pediatric pulmonologist at the Neuromuscular Pulmonary Clinic at Schneider Children's Medical Center. Today we'll talk about the respiratory management in Duchenne muscular dystrophy, especially at the non-ambulatory stage. We all know the importance of respiratory care in Duchenne muscular dystrophy. Historically, respiratory failure has been the leading cause of mortality. But today, the non-invasive respiratory support, the steroid treatment, symptomatic respiratory management have expanded the life expectancy. As you all know, Duchenne is a progressive disease. Along with the weakness of the limbs, the patient experiences weakness of the respiratory muscles. At early stages, this weakness is asymptomatic and appears only at pulmonary function tests. But along with the progression of the disease, and especially when the patient loses the ability to walk, symptoms will gradually appear. The weakness of respiratory muscle will express in decrease in vital capacity, and the functional lung volumes will be lower. The weak paraspinal muscles also donate to the situation by decreasing the support to the spine, leading to scoliosis. The spinal scoliosis will change the chest structure and will create pressure on airways. This is another reason for a decrease in lung volumes. All of those will create restrictive respiratory disease with lower effective lung volumes and air trapping. With time, the chest will become stiff and the respiratory rate of breathing will lower, which will create hypoventilation, will be expressed with high CO2 levels. Eventually, respiratory ventilation support will be needed. But not only the volumes will change. With time, the respiratory muscle will continue to deteriorate and the power to create an effective cough will get lower. The peak cough flow of a grown is usually higher than 300 liters a minute. Duchenne patients suffer from reduced power to cough and thus lower peak cough flow. While a simple viral infection for a healthy man will create only some rhinorrhea and mucus, and this healthy man will easily cough it out and get rid of the phlegm. Instead, with Duchenne disease, there is a low power to cough, and the phlegm will stay in the airways and might cause pneumonia and atelectasis. At late stages, recurrent airway infections will add to the creation of an obstructive respiratory disease and more difficulties. The patients admit that they have difficulties to evacuate secretion from the airways, and thus they suffer at simple viral or bacterial pulmonary infections. At late stages, swallowing difficulties will appear. The drooling might come, and a long aspiration of food or drinks or saliva. All will cause inflammatory lung reaction and chronic airway disease. Respiratory complications are a major cause of morbidity and mortality. The respiratory muscle fatigue will cause hypoventilation in time and will cause, as we said before. Then there will be mucus plugging, atelectasis, pneumonia, and at the end, respiratory failure. If left untreated, patient will experience severe dyspnea, lengthy hospital admissions, and eventually death due to respiratory arrest or respiratory-induced cardiac arrhythmias. Here at Schneider Children's Medical Center, we treat them at the neuromuscular clinic. We suggest a routine clinical appointments every 6 months, unless otherwise specified. If there are respiratory complications, we invite them to come more often. The routine evaluation of the respiratory function will include history taking. We carefully evaluate patients for evidence of respiratory symptoms, for obstructive sleep apnea symptoms, or oropharyngeal aspiration or gastroesophageal reflux symptoms, and we ask for asthma symptoms. The examination will include, of course, the chest examination, the back examination, looking for scoliosis, and saturation. We'll do lung function tests. We will measure CO2 with capnograph or transcutaneous CO2 measurement. We will do annual chest radiograph. We will look for the position of the diaphragm, and we will look whether there are signs for atelectasis or infiltrates. If there is sputum, we will collect sputum culture. The pulmonary function tests will include spirometry, the lung volumes, the inspiratory and expiratory maximum powers, the peak core flow, and CO2 transcutaneous or biocapnography. With progression of the disease, there will be a decline in all pulmonary function tests, but the forced vital capacity, the FVC, is the most predictive measurement. As you can see, this is an example for FVC in Duchenne patient and versus healthy patient. In childhood, FVC will rise and reach a peak, then will follow by a plateau, and then deteriorate over time following the loss of ambulation. As you can see here, the absolute FVC measurement and the peak expiratory flow that we can see the same. They rise at childhood, then reach a plateau, then decline. Not only in studies, but also in the clinic. This is an example of my patient, a 70-year-old boy with Duchenne. He was diagnosed at the age of 5. He lost ability to walk at the age of 9, he refuses to all treatments. As you can see, his FVC is 27% predicted for age. Under FVC below 30% predicted for age, one might easily suffer from respiratory complications with every minor viral infection. Here we can see more lung function tests. As you can see, the FVC and the TLC, which is the total lung capacity, they are more predicted and more related and correlated with age and with progression of the disease. This is the line for healthy patients, and the black line, the black dots, are for Duchenne patients. As you can see, it's just starting with the rise at the beginning of life, and by the age of 10, 12, there is a plateau and then a decline till they suffer from respiratory failure. Sleep studies are necessary to diagnose sleep apnea or hyperventilation. Sleep studies can also be used as an alternative method among kids who can't cooperate with pulmonary functions. Now, after we evaluated them with pulmonary function tests and sleep studies and chest X-ray, we have to treat. First, I recommend prevention. Prevention of deterioration and prevention of infections. Prevention of infections, we recommend yearly immunization with influenza vaccine and we recommend pneumococcal vaccines. Patients and their caregivers should be educated about respiratory complications of respiratory infections, and we recommend influenza vaccine for the whole family. Corticosteroid treatment changed lives with Duchenne. The respiratory deterioration, along with other aspects of the disease, is delayed. As you can see, the FVC is much higher for steroid-treated Duchenne patients. The red line is for treated Duchenne patient treated with corticosteroids, and the blue line is the line for those who are not treated with corticosteroids. The rate of decline is actually similar, but they started from a higher point. The respiratory treatment must include physiotherapy, hydrotherapy, and active physiotherapy with tree flow or other positive pressure devices like those. Active physiotherapy is just blowing against positive pressure, and at late stages we recommend also passive physiotherapy by professional therapists, also to prevent respiratory complications. The physiotherapy will help to preserve lung compliance, lung volumes, and to help the mucus expel. The cough assist machine is a great device. Not only does it help to expel phlegm, but also to preserve lung volumes by providing lung inflation and preserving lung compliance. I recommend to hear the cough sound of the patient and to watch the chest expanding in physical examination at every visit in the clinic. Also look at the chest X-ray and then consider using the cough assist machine. The indication to begin cough assist machine, according to international guidelines, is when FVC is less than 50% predicted for age, or peak cough flow is less than 270 liters a minute, or the maximal expiratory pressure value is less than 60, accompanied by lung infection, or with a peak cough flow of less than 160. now we already have complications, we must treat complications. First, we need to treat pneumonias or atelectasis with signs of pneumonia such as fever or dyspnea, cough, wheals, or sputum production, and early treatment is a must. We recommend to start early with respiratory physiotherapy, with antibiotics, the cough assist device, continue corticosteroids, add inhaled bronchodilators, and consider the use of BiPAP for recurrent atelectasis especially. When we have obstructive sleep apnea or hypoventilation or already respiratory failure, we must help the patient with non-invasive ventilation, which is the BiPAP. This is the machine and this is the mask. There are a few different masks, like the full face mask or the nasal prongs and the nasal mask. Nocturnal assisted ventilation with backup rate of breathing is recommended when there are signs or symptoms of sleep hyperventilation or other sleep disorders, as we can see in abnormal sleep studies, or when FVC is below 50% predicted for age, or the maximum inspiratory pressure is below 60, or the wake or the sleep baseline is below saturation of 95% or CO2 above 45. Assisted daytime ventilation is when, despite nocturnal ventilation, the saturation at daytime is below 95 or the PCO2 is above 45, or we have symptoms of dyspnea at awakeness. When we have pulmonary complications during pulmonary infections, we must increase the pulmonary treatment, because during simple viral or bacterial infections, Duchenne patients may have difficulties in the mucus removal. They will have mucus plugs, will cause pneumonia. There will be a ventilation perfusion mismatch, and then they may have desaturation. Do not treat with oxygen alone. Use the BiPAP. If there is already a use of the BiPAP, increase the inspiratory pressure in the BiPAP, or increase the delta between inspiratory and expiratory pressure. Increase the time of BiPAP used during the day, and increase time of use with cough assist machine. At very late stages, when the patient reaches respiratory failure, BiPAP use will become continuous during the whole day. At its past, this situation was a time to recommend for tracheostomy. But nowadays, tracheostomy is not gradually recommended. Tracheostomy can be discussed with the patient and the family and can be done when preferred by the patient. But he can also use a continuous BiPAP, and it's also a better solution with a higher quality of life and preferences among Duchenne patients and their family. This is the end, and now I can answer some questions. Thank you.
Доброго дня. Хагіт, ви на зв'язку з нами, ви нас чуєте?
Hello, Hagit. Can you hear us?
Hello.
We welcome you at the conference.
Так, Хагіт готова відповісти на ваші питання. В нас питання в чаті.
So we've got one question in the chat.
Добрий день. Питання пульмонологу. Пневмококова вакцина по інструкції робиться кожні 5 років, так як правильно, щороку чи по інструкції?
So Hagit, the question is concerning vaccination. to be correct, the pneumococcal vaccination. And according to the instruction, it is said that it is done every 5 years. And what are your recommendations? What are your suggestions to do it every year, or according to the instruction, every 5 years?
No, nowadays the recommendation has changed. Usually in the past we recommended every 5 years, but now we recommend to do the Prevnar vaccine and then the Pneumovax vaccine, and then you don't have to do it again every 5 years. So it's just to give all these those two vaccines, and most children with Duchenne nowadays, after actually getting those vaccines during early childhood, in the regular program of vaccination for children, need only the addition Prevnar and Pneumovax, only those two vaccinations in order to prevent pneumococcal infection.
Could you if I understood you correctly, so two vaccines, one vaccine is pneumococcal and it is done at what age?
Those two vaccines are pneumococcal. Actually, in Israel, I don't know how it is in Ukraine, but in Israel, every child is getting pneumococcal vaccine at the age of 2, 4, and 12 months. It's in the regular program for all the children, not for Duchenne, just for Duchenne, all the children. But for Duchenne children, once they start to have respiratory complications, which means once the lung functions are not normal, we recommend to add 2 pneumococcal vaccines. The first is the Prevnar vaccine, and the second one is called Pneumovax. Both of them are vaccines for pneumococ, but they will give the whole types of pneumococ covering in order to prevent pneumococcal infection, and then you don't have to repeat it every 5 years.
Okay, thank you, clear. Отже, Хагіт відповідає, що зазвичай пневмококова вакцина робиться у віці 2-4 місяців і потім у віці 12 місяців, тобто двічі. Якщо немає потреби повторювати кожен рік чи кожні 5 років, а також Хагіт зазначала, що раніше справді повторювали кожні 5 років, але наразі робиться 2 вакцини, як я сказала, 2-4 місяці і 12 місяців, і на цьому все. Але якщо це про всіх дітей, да? Що стосується дітей, хворих на м'язову дистрофію Дюшенну, то як тільки вони починають мати респіраторні проблеми, то рекомендується ще 2 пневмококові вакцини спеціальні, які прописані, і таким чином це повністю, ми усунемо предотвратим заболевание, так, захворювання.
Дякую. Анатолій Володимирович Царенко, ви на зв'язку? Немає на зв'язку. Може, ще в когось є питання? Да, Хагіт Левін.
Хагіт, and could you repeat the names of those 2 more vaccines that you add if a Duchenne child has starting to have respiratory problems?
You mean for pneumococ, the Prevnar and the Pneumovax?
Yeah, just
Prevnar and Pneumovax.
Prednalin and...
Actually, I don't know why you're asking so much about the pneumococ, because actually influenza is much more severe in Duchenne patients. So I would recommend mostly about the influenza vaccine every year. But as I said, we also recommend to get the vaccine for pneumococ.
Thank
The
you.
difference between those two vaccines for pneumocock, maybe in Ukraine there is a different commercial name, but the idea is to cover all the types of all the serotypes for a pneumocock, which means to get two vaccines.
Thank you. Хагіт говорить про те, що ще дві вакцини є предналін, але в принципі звертаю нашу увагу на те, що можливо питання не полягає саме в пневмококовій вакцині. Що є більш важливішим для таких дітей, це щорічна вакцинація від інфекційних захворювань. Так, від інфекційних захворювань щорічна вакцинація для таких дітей є обов'язковою, оскільки для них ризик захворювання, будуть дуже сильні ускладнення.
В мене таке питання. Скажіть, будь ласка, у нас в Україні є родини, які далеко живуть від лікарень, які не проходять щорічне і 2 рази на рік обстеження планове, як це потрібно робити. Але якщо дітям уже по віку є проблеми вже з дихальною системою, що може бути для профілактики таких дітей, для запобігання ускладнень? Можливо, якісь чи надувальня кульків, чи ще щось, якісь фізіотерапевтичні вправи?
We've got one more question. We can say that in Ukraine there are a lot of cases when children can't get to hospital every year or twice a year. Unfortunately, they don't have such an opportunity, and the doctors don't see them twice a year. But if children start having some respiratory problems, maybe you can recommend them some exercise like blowing a balloon or something like that to train their respiratory function.
Of course, I said in the presentation that we recommended to do a physiotherapy, respiratory physiotherapy, include doing some blowing, some blowing activities. I had it was a picture in the presentation, but here it is. We have it. This is the tree flow, which we recommend all the Duchenne patients to practice with this and blow. We don't recommend balloons because balloon can blow, but and it's not a recommended activity. But we recommend to blow to bubbles and with straw in water. And also we give this tree flow to every Duchenne patient, and we tell them how to blow and to take inspirium and expirium every day. We recommend daily respiratory activity with it, and they can play with it during watching TV or during watching doing things on the computer, and it's very easy and it's fun. So of course we recommend respiratory activities between visits.
Yes, thank you. I'll translate. Так, як я зазначала в своїй презентації, респіраторна фізіотерапія є обов'язковою для лікування таких дітей. Ці вправи мають бути просто щоденні, обов'язкові. Ми, в принципі, не рекомендуємо там надування шарики, наприклад, просто тому що цей шарик може лопнути, так, і це не дуже трошки емоційно може бути, але є спеціальні, по-перше, спеціальні ось такі, як показувала Хагіт нам, такі пристрої для того, щоб дитина так гралася ним, просто дула, шарики піднімаються, і дитина може це робити щодня, просто дивлячись телевізор під час там ігри, в комп'ютерні ігри, постійно. Також можна просто дути якісь мильні шарики надувати, можна через соломінку воду дути, просто щоб дитина постійно дихала так, щоб виконувала такі вправи щодня постійно, обов'язково.
Якщо дитина регулярно займається, плаває в басейні і надовго може затримувати дихання під водою, чи може це якось характеризувати, що добре працюють легені в дитини, чи ні?
One more question from Dushan mother. So her child goes to the swimming pool actually regularly, and he practices such exercise like he doesn't breathe for a long time actually. And does it mean that he has rather good respiratory functions?
No, it doesn't mean anything, but it means that he's practicing his lungs, and I really recommend to continue swimming. Hydrotherapy is very, very recommended as a respiratory therapy, but I recommend to do it with some guide. I mean, it should be not that the child is alone under the water, but with someone, a specialist that his specialty is with hydrotherapy, giving the child the treatment with how to swim and all the practice in the water that will increase or will prevent decreasing of his lung function. Swimming is very good for the lung, very preventing the deterioration of lung function, and it's very recommended, but not just holding breath under the water. But actually, the thing that is improving his lung function is the thing that he is taking lots of air and doing a very big inspiration before. So when he is getting lots of air inside the lung, this is what is good for his lungs, not the holding, okay? Not the holding of the breath, but taking a big inspire, which is making the balloons inside the lung bigger and increase the lung volumes. This is what we want to preserve the lung volumes.
Thank you. I'll translate. Те, що він затримує подих під водою, в принципі, не говорить нам ні про що. Це не говорить нам про те, що в нього гарна функція легень, але Хагіт рекомендує відвідувати басейн, чим більше, тим краще, виконувати вправи в басейні. Єдине, що вона наполягає на тому, що такі вправи мають бути під наглядом спеціаліста. Гідротерапевт має певні давати вправи, які б допомагали лікуванню дитини, бо такі вправи у воді, плавання, воно є, допомагає попередити і погіршення функції легень і, в принципі, роботу м'язів так само. Тобто, якщо дитина, як ви говорите, довго тримає повітря, затримує повітря, то що це означає? Що він набирає, значить, собі в легені як можна більше повітря, і потім, щоб довго його тривати. Тобто, це значить, що він тренує легені, він максимально їх роздуває, і це є дуже добра вправа для нього, так, для збільшення об'єму легень. Но наскільки довго він цей повітря в собі тримає, це не є важливим. Але як вправа, чим що він багато набирає і видихає, потім також для видиху, для тренування видиху, ця як вправа, це добре підійде.
Дякуємо за запитання. Дякуємо за відповіді. Хагіт Левін. Дякуємо. В чаті в нас вже немає питань. Дякуємо, Хагіт.
Таке питання. Скажіть, будь ласка, якщо пацієнт своєчасно застосовує неінвазивну вентиляцію легень, чи є ризик захворювання респіраторними інфекційними захворюваннями та їх ускладнення? Чи все ж таки це запобігає і є як профілактика?
One more question from a mom. So if a child uses non-invasive nocturnal home ventilation every night clear at home, does it mean that he won't have any respiratory infections?
No, it's not related. He can have respiratory infections, but the nocturnal non-invasive ventilation will help him to preserve the night ventilation, and it will help to prevent recurrent atelectasis. It will not prevent respiratory infection. They will come, but if they will come, they might help him to prevent complications.
Okay, clear, thank you. Ну, Хагіт говорить про те, що використання домашньої неінвазивної нічної вентиляції легень не говорить про те, що дитина не матиме інфекційних захворювань. А все одно інфекційні респіраторні захворювання, вони прийдуть, але така домашня вентиляція легень, вона допомагає уникнути ускладнень.
Все, дякую. Питань більше немає. В нас не в чаті, ніхто не задає питання. Дякуємо, Хагіт.
So we are very thankful to you, Hagit, for all your answers and for your lecture. We have currently no more questions to you, and we were very glad to see you at our conference.
Thank you very much for the invitation.